I wanted to talk about variation. Variation has been my assigned windmill this year. It's basically something that will never change, and my talk is totally worthless in terms of doing this, in terms of impressing you about why we should try to narrow variation. Dr. Hoffman's assigned topic this year to be windmilling at is overdiagnosis. So we've been assigned those. Fortunately, the year's coming to an end, and we'll be relieved of this burden. But this is this year's burden. So I wanted to talk a little bit about variation because it is actually one of the important things that, at least in the U.S., we're trying to deal with, because we spend so much money in healthcare and we have this Obama program, which has greatly increased the number of people who will be covered by insurance. And so the issue will be, can we afford all of this? And we spend 18% GNP on healthcare, twice what the Canadians do or the Australians or any other civilized country does. So the idea is we're supposed to be kind of we're insuring more people, but we have to cut back on our costs. And so there are a couple of ways to do that. Narrowing variation is probably the hardest. For the Americans, we have large opportunities associated with the Affordable Care Act, what we call Obamacare, in terms of we're short on providers. We don't have enough primary care doctors, and this is a huge opportunity for PAs and NPs to expand what they do and get into the system. I don't think if I would to advise somebody, do you want to do something and learn in 2 years and come out and make $100,000 a year, I'd say become a PA or NP. So the challenges for the emergency department now are a little different. One of them is going to be, we're going to become the admission center or the distribution center for patients, because one of the things that is coming up now is, right now in these states we have a kind of silly law that basically says if you're a Medicare patient over 65 and you need to go to a nursing home, well, first of all, you have to go into a hospital for 2 days as a 2-day rule. So it's kind of silly because the patient maybe could go right to a nursing home. They're going to get rid of that rule. And so the emergency department's going to basically have 3 decisions. Number 1, can we put this person directly in in a nursing home? Number 2, can we put this person in the observation unit for a day or 2 and spiff them up there without technically admitting them to the hospital? Because there's some financial issues regarding observation versus admitting to the hospital. So I just saw recently a course for emergency physicians on observational medicine, because the idea is we don't really necessarily know how to take care of somebody for 2 days. And so that was the thrust of this course, because if emergency physicians were going to do it, maybe we could learn how to do it most efficiently. If they have the hospitalists do it, then we have to kind of get along with them. So there's the holding area. We're going to put you for a day or 2. You got asthma, gastroenteritis, something like that. And then there's the patients who do need to go into the hospital. So 60% of the patients who go into the hospital, we control, basically. And so the opportunities for us to kind of help the hospitals in terms of the distribution of these patients is really going to be something I think that's going to be an opportunity. The other thing is that we're supposed to increase our productivity. We're supposed to go faster, see patients more efficiently. You know, we have scribes now in the States. We have PAs and NPs helping in the States. We have all of these things that are trying to allow us to see patients more quickly. Unfortunately, we have other things that are inhibiting that, electronic medical record being at the top of the list of things that are inhibiting doctors from moving more quickly, because in emergency medicine, we see 2.5 patients an hour. That means 2.5 histories and physicals, 2.5 progress notes, 2.5 sets of orders. Nobody generates histories and physicals like we do. You know, they don't do, when a patient gets admitted to the hospital, how many admissions does a doctor have a day? We have 2.5 patients an hour that we have to do history and physical on, and all of these other kinds of things. And so the idea is to facilitate the work of these folks. And in fact, right now, it appears to be largely encumbered with electronic medical records. And then the last thing we have to do is basically try to narrow our variability, which is really pretty extraordinary. Let me give you a few examples. Well, it's not obviously unique to emergency medicine. It's throughout medicine in general. So there's this thing called the Dartmouth Atlas, which looks at Medicare patients and the care that they receive across the country in terms of its variability. How many people get this in this region get treated this way compared to that region? And basically, it shows some really embarrassing things. Let me just give you a couple examples. In 2010, the average annual Medicare spending per capita varied from the lowest, being $6,911 a year in Minneapolis, to $13,824, virtually double in Miami. Now, this is all adjusted for the degree of sickness and those kinds of things. So the Medicare patients cost twice as much in Miami as they do in Minneapolis. There's a thing about their prescriptions. In Miami, the average number of prescriptions given out to Medicare patients is 63 per year, which is 63 per year. Grand Junction, Colorado, 39. So these differences are not subtle. They're not 10%, 20% difference at all. You know, we're talking in one case 100% difference in the costs. What about things like the regional, you know, what they do in terms of care by region? There's an older study of breast cancer surgery. You know the idea of the lumpectomy, the breast sparing surgery. They looked at where that was being done. It was the thing to do. Well, in Columbus, Ohio, one state, Columbus, Ohio, 12% of the patients had breast-sparing surgery. In Cleveland, Ohio, 23% of the patients had breast-sparing surgery. In another town in Ohio, Elura, strange name, 48% of the patients had breast-sparing surgery. So 12, 24, 48. This is in one state. The data is all the same, patients are all the same, and yet 4-time variability in terms of doing a simple thing like, you know, breast-conserving surgery. In emergency medicine, the literature on this is enormous. I went through our database. I guess I should explain the book a little bit. So here, those of you who haven't been here before, we have abstracts in there from this fabulous service, called Emergency Medical Abstract, started in 1977. That was the Mesozoic period, emergency medicine. Some of you were not born. And we started doing this. That we survey 600 journals a month. Dr. Hoffman is my colleague in this endeavor, and we have like 15,000 papers in the database. And every year let's pick some topic. Let's see what our articles have to say. Let's put it into some kind of reasonable order. Let's let the faculty add their 2 cents and distill it down. So the idea is, hopefully you won't have to take any notes, but also the idea is that when you go home, you can say, well, here's 4 papers that suggest why don't we do it this way? Because the idea is, if you go home and do it the same way you're doing it, it's not a good use of your time to be here this morning. So the idea is to motivate, look at what we do, and have the information to precipitate changes. So this chapter is just full of examples of variation. But the fact of the matter is that I would like to limit it to just a few examples. First of all, there are many papers in here that compare hospitals. They say hospital A versus hospital B, and they show big differences. And another version of these studies is hospital A, then we make some intervention, and then we, in hospital A, they say, now let's look at before and after. Before and after we did this intervention, let's see whether we are doing better or not. So that's another model. The model I like the best, however, is the one that looks at individual physician practice. Because when you compare hospital A with hospital B, well, that's really kind of like misleading, because the fact of the matter is that hospitals don't order tests, doctors do. So the results of the hospital's testing is the composite of what all the doctors ordered. So let's drill down and see if we can some examples of variability in doctors. Because one of the phenomenon that you see is we compared hospitals, and hospital A turned out to be very similar to hospital B. But when you drill down to hospital A, the variation is huge. But when you average it out, it comes to be here. And this one, hospital, the variation is huge. And I'll show you some examples. But when you average it out, the average is here. So the 2 averages look the same and say, well, these hospitals are the same. Well, they are the same when you look at the averages, but when you look at individual physician behaviors, it's astonishing. So I want to jump around a little bit here, and I want to save what I think to be the best for last. So let's, here's a typical paper. This is number 5. This is about the variability in care provided children who were hospitalized with pneumonia. And what they did is they looked at 21,000 kids hospitalized for pneumonia at 29 different hospitals, 29 hospitals. All of these hospitals were feeding in information into this pediatric database, and they looked at the variability between them with regards to the tests that were performed and the things that were done for these children. As an example, one hospital, serum electrolytes, 68% of the kids with pneumonia got electrolytes. Another hospital, 0% of the kids got electrolytes. Arterial blood gases, which you would think would be rarely needed in a kid admitted to the hospital with pneumonia. One hospital, 1%. Another hospital, 17%. 1 in 6 kids got arterial blood gases, my goodness. Blood cultures, there you go. 0%, 79%. Inexplicable kinds of things. CBCs, basically you come in a hospital and get a CBC. One hospital, 29%. Another hospital, 92%. They then expanded the study. They then looked at 36 hospitals, 100,000 kids, and basically showed the same huge variability in these kinds of things. So when we go through this, we see over and over and over again some. Let's look at number 6. Hospital admission decisions for patients with community-acquired pneumonia. This is a physician study. They note that inpatient care is 25 times more than the cost of outpatient care. So they looked at, this is from LDS Hospital, and this is the Latter-day Saints Hospital in Utah. Very famous hospital, part of a large health system up there, Intermountain Health. They do a good job, as best as when they compare themselves with others. Admission rates by emergency physicians for kids with pneumonia. Now they're looking at 2,069 kids, so it's going to be hard to say my admissions are sicker than yours when you're looking at 2,000 admissions. The admission rate range from 38% to 79%. So there's one doctor who's admitting twice the number of patients as the lowest doctor. So you wonder, well, what's the right number, 39% or 78%? And it's virtually impossible to tell, because if you use markers like, well, they wound up coming back to the hospital because they were, they shouldn't have been discharged, they should have been admitted, those kinds of things, or lawsuits, or anything that you can think of to compare these two groups. It's such a crude measure that it really doesn't do the job very well at all. There's paper 7, variation in opioid prescription. There's 8 is variation in antibiotic prescription by location. If you want to get antibiotics, go to the south. That's where they give them out like water down there. If you want opioids, probably come to Los Angeles if you want opioids. So 9 is on antibiotic variation. 10 is on dizziness. This is a Kaiser study, and the nice thing about Kaiser is that it is kind of a closed system. All the doctors are employees, and they basically can work together to come up with some guidelines on how we can behave. It's probably the ideal format for trying to get physicians to narrow their behavior, because we're all working together for the common good kind of thing. So this is a Kaiser study. They looked at dizziness. They looked at 20,000 patients in 20 of their hospitals, and basically found the CT utilization, 20% in one hospital, 33% in another. The variations, 50% variation. MRIs for dizziness, 0.8% in one hospital, 6.2% in another hospital. 0.8 versus 6.2 is a spread over 20 hospitals kind of thing. The rate of neuroimaging was not predictive of a higher rate of stroke diagnosis. So what you find in these studies is the hospital that does the most of the tests don't find that they've got more of the pathology than the hospitals that do the least. That would be nice if that were true, but unfortunately it isn't. What about head CTs? Man, you talk about radiation, it's probably our commonest CT. Number 11 is a physician study, and it looked at 38 physicians. This is about the 3rd study that the Brigham and Women has published. I can't understand why they do that. They look at the individual behavior of the physicians and the teachers, not the resident, in their department at Brigham and Women's, and they keep on publishing studies that are embarrassing, and I don't know why they keep on doing it. Whoever's publishing them should have been taken out and just gotten rid of, like, in Boston, they have ways of getting rid of people in Boston, kind of thing. Get rid of this guy because he's embarrassing the Brigham and Women's every time that he does one of these studies. Well, this was looking at variation in head CTs across the board, 38 doctors, Brigham and Women's, unadjusted rates for CT scanning for heads. One doctor was at 4.4% and another doctor was at 17%. Fourfold difference. Now, we're looking at, this study had a large number of patients. So again, it went from 2000 to 2006. Tons and tons of patients. One doctor's at 4%, another doctor's at 17%. Of all the people coming into the emergency department, there 9% of them had head CTs. When I think of my own personal experience, like I worked at a community hospital here for 25 years. I was a director. And we would admit 20% of our patients, which I think is pretty much the national average. I mean, some places are higher, some places lower, but I can tell you 20% is about the number. So we had a, what I would view as a very typical distribution of patients. And when I look at this and say, 1 in 11 patients coming in the door is going to get a head CT at our hospital, would never happen. So this is a teaching hospital. And you wonder, what are they teaching their residents? What are they teaching this putty in terms of ordering? 1 out of 11 patients walking in the door gets a head CT? Hard to conceive of. And the subset of patients with headaches. Kind of interesting subset. 15% was the low, 62% was the high. 62%, one doctor, 62% of the patients got CT for headache. Another doctor was at 15%. So that's, again, a fourfold difference, fourfold. So we're not talking 10%, 20%. And we're not talking about CBCs or something minor. Nobody cares about, you ordered more CBCs than your friend. But this is radiation. This is kids. This is long-term sequelae of this kind of thing. And this is related to, what appears to be inordinate fear. Why don't you just take these kids, sit them in the corner for about an hour and see how they do. And if they don't throw up and they're running around the place and terrorizing all the other patients, get that little bastard out of there. He's okay. They had a really very weak study that's in our database about observation. And the idea would be, okay, you put the kid and you watch the kid for a while. And it really was very disappointing. They watched the kid for about an hour. And they find out the number of CTs was essentially the same whether they watched them or not. That's not watching a kid. You can't watch them for maybe it takes a little bit longer to do that. Or maybe these doctors were such fraidy cats that it didn't really matter what the observation said. They were going to scan these kids. Number 12, variation in head CT in trauma. This is again from the same place. They should just turn themselves in. This is 2009 data, 7,900 trauma patients. The use of CT scan for head trauma varied from a low of 7% to 24%. They had one guy who was an outlier. They didn't even include this one guy in the averages because he was so far out there. One guy was ordering head CTs in 42% of his patients. The other guys, 7% to 24%. This guy is Mr. Fraidy Cat out here, 41%. He's faculty, teaching residents how to be risk averse. It's just frightening, I think, honestly. 13 is a department study. CT for minor head injury, variation trends in major U.S. Pediatric emergency departments. So this is head CTs in kiddies. This is looking at data from 2005 to 2009. So it's old data. It's 40 hospitals, though. 40 hospitals in 17 metropolitan areas across the country. So it's really very representative of what's going on out there. This is not like, well, these are outliers. This is looking at, it only looked at 9 million kids. A small study, rate of CT imaging among children with minor head injury ranged from, this is by hospital, 19% in one hospital, 58% in another hospital. Now these are little kids. The whole idea here is to back off. We're concerned about the amount of radiation these kids get, unnecessary radiation. And there's two issues. One of them is, radiation can cause cancer in some subset, maybe 1 in 2,000, 1 in 3,000, something like that. But the most frightening thing about radiation to a kid's head, particularly a young kid's head, is this one study that we have in the database from somewhere in Norway or Sweden, where they basically found that the amount of radiation from a CAT scan was similar to the amount of radiation that was delivered to radiate hemangiomas on the faces of kids there. So this is a closed system. I think it was Norway, Sweden, one of those places. So they found that these kids who had the hemangiomas irradiated had a similar radiation to those kids who were getting CAT scans. So they measured the school performance at the end of grade school. They all took a test. They had a national test. Kids who had a CAT scan did worse on compared to the average for all the kids taking the test. They also had a test when they got out of high school before they went into the military. These kids who had a CAT scan all did their average IQ or performance in these tests was less than the average kid, suggesting, certainly not proof, that radiation to your head may affect your intellectual capacity, which is something which is worse than cancer. If you get cancer, it's 1 in 2,000, I'll take my chances kind of thing. But, the idea of irradiating a kid and turning down his intellectual or her intellectual capacity is just frightening, the idea of doing that, or the potential for doing that. In any case, more of the same. Number 14, I don't want to do 14. Yeah, here's an interesting one. We'll do this. Well, let's get on to the one I like the best. There's at the end of the chapter, there are four papers, and all of them look at something that where what we're doing is pretty substantial. It's like this is about CTPAs for suspected pulmonary embolism. And the first paper I think we're looking at is, I have it. Okay, it is number 18. So the idea here is pretty straightforward. The idea is if you have a patient who you think may have a pulmonary embolism, you have to stratify them clinically, low, intermediate, high risk. You have to do that whether Wells score, Geneva score, or your own Gestalt. And if a person is considered low risk, then the usual algorithm is, okay, let's do a D-dimer. If the D-dimer is negative, the workup is over. If the D-dimer is positive, you have to do CDPA. That's the theory here. It's very straightforward kind of thing. Well, that being the case, not very complex at all. How are people doing? Here's four studies looking at the utilization of CTPA in people who, they're all low-risk patients. All four of these studies are low-risk patients. Number 18, 35% of low-risk patients underwent D-dimer testing. And only 35% of low-risk patients had D-dimer testing. They're all supposed to have D-dimer testing if they're low-risk and you're considering them for PE. Had D-dimer testing been done, they calculated a substantial subset would have avoided CTs, 9% in the PERT group, 14% in the Wells group. Well, 9 and 14% decrease in the necessity for a CT, that's nothing compared to the other papers. The next paper, 7% of patients with low risk, and a negative D-dimer wound up getting a CTPA. None of them are supposed to get it. Of the low-risk patients who had a positive D-dimer, only about 60% of them had a CTPA. It's like nobody's following the rules, but they're not following the rules like to a huge degree. So a lot of people are getting CTPAs who don't meet my criteria. There's the issue of dye for their kidneys. There's the issue of radiation. They're getting a lot of radiation to their chest in this process. So we're not talking about, well, it's a CBC. No, it's a CTPA. It's kind of a big deal. 18, 19, 20 is the same thing. Patients with a negative D-dimer were imaged 14% of the time. They're not supposed to be imaged. And of those who had a positive D-dimer, low risk, positive D-dimer, they're all supposed to get imaged. 53% got imaged. The other paper is 58%. They're all supposed to get imaged. And 21 is the same. It is 4 papers showing huge variation in something that's really quite substantial, where there is a belief that what I said at the beginning, low risk D-dimer, negative, you're done, positive, CTPA, ought to be done. So there are some challenges here. My time is up. I will probably, at the talk at the end of today, go over some of the ideas I think we could embrace to kind of try to attempt to narrow a variation if we wanted to.